Hello, everyone. This has been a really great week. I have learned so much and made so many new connections, and for that I'm very grateful, in addition to this opportunity to share my research. So today I'll be discussing some of my work, which focuses on examining the impact of comorbid PTSD and childhood trauma on ketamine's efficacy in treatment-resistant depression. So at this point in my career, I don't have much to disclose except for some salary support that I receive from the Ontario Graduate Scholarship and the Canadian Institutes of Health Research, although this project wasn't directly funded by either. So here's an outline for my presentation today. I will be presenting two different but related analyses, the first on PTSD comorbidity and the second on adverse childhood experiences. I will then end with some conclusions and next steps to address our inherent limitations. So for the first part of my presentation, we'll be discussing the comorbid PTSD and TRD analysis. So PTSD is often a very difficult to treat psychiatric disorder for which very few pharmacological therapies are currently available. And unfortunately, when it's comorbid with depression, it can be even more difficult to manage, and we see greater symptom severity as well as reduced responses to traditional interventions. So given the lack of effective treatments and the success of ketamine for TRD, as we've seen throughout this conference, some groups have assessed ketamine's efficacy for PTSD, as we heard a little bit earlier as well. So as you can see, I've included some of these studies on the slide, and notably, these are the ones that did not combine ketamine with a psychotherapy protocol or perioperatively for acute PTSD. So now the key takeaway here is that some of these earlier studies found rapid reductions in PTSD as well as depression symptoms, but then we see a larger scale study that was conducted more recently where there was no significant difference in PTSD symptom response compared to placebo. So a little bit of mixed findings here, and the field doesn't seem to be entirely sure of what we're looking at. So given these mixed results, we aim to determine how comorbid PTSD affects the antidepressant efficacy of ketamine for treatment-resistant depression and whether ketamine is effective at reducing those comorbid PTSD symptoms. So here I'm hypothesizing that the antidepressant efficacy of ketamine would be reduced by the presence of PTSD comorbidity, and then I'm further hypothesizing that PTSD symptoms will be unaffected by the treatment. So I conducted a retrospective post-hoc analysis of real-world data collected from the Canadian Rapid Treatment Centre of Excellence, or CRTCE. These are outpatient community ketamine clinics run by my supervisors, and we're actually some of the first Canadian clinics offering IV ketamine to adults. Important to note here that these clinics are considered private, meaning that patients are paying 100% out of pocket or through insurance. So just a little caveat there. Now, briefly, since we are working with a real-world sample, our inclusion criteria are much less strict than some clinical trials. So, for example, our patients could have a primary diagnosis of MDD, BD, PTSD, or OCD, as long as they're experiencing a treatment-resistant major depressive episode within that disorder. Many patients also had a high level of suicidal ideation and other psychiatric comorbidities. Our main exclusion criteria are related to contraindications to ketamine, such as substance use disorders or uncontrolled medical disorders, as well as psychotic symptoms. So for this analysis, you can see we had 144 patients, 18 to 65 years old, with treatment-resistant depression, so they were experiencing a major depressive episode. I further divided these patients into two groups based on PTSD comorbidity. So this first group here, with an N of 77, scored greater than or equal to 3 on the PC-PTSD-5, which is a primary care PTSD screen for the DSM-5, so a screening questionnaire. And they scored greater than or equal to 33 on the PTSD checklist for DSM-5 or the PCL-5. This group over here, the non-comorbid PTSD group, which had an N of 67, scored less than 3 on that PTSD screener. Now, we did have another group of patients, which was 25, who I considered as a sub-threshold group, where they scored greater than or equal to 3 on the PC-PTSD-5, but they scored less than 33 on the PCL-5. So for sensitivity and specificity, we decided to remove these patients for this analysis. Now, all of the 144 patients received 4 sub-anesthetic infusions of ketamine over 2 weeks, which we dosed at 0.5 to 0.75 milligrams per kilogram. So patients had the opportunity to increase their dose after the first 2 infusions from 0.5 milligrams per kilogram to 0.75 milligrams per kilogram if the antidepressant effect was not sustained or not effective. And depressive symptoms here were assessed at each infusion, so infusion 1, 2, 3, and 4 with the kids. PTSD symptoms were assessed with the PCL5 before infusion 1 and after infusion 4. So the main thing I want to highlight in our demographics was that these 2 groups were very similar at baseline. The PTSD group had a slightly higher kids in GAD-7, you can see here, but nothing that was really significant. So I conducted a repeated measures ANOVA and SPSS to compare the effect of comorbid PTSD on depressive symptomology by measuring the change in mean KID score for each infusion. So my analysis revealed that mean KID score declined significantly over the 4 infusions. So you can see here a steady decline, and we actually did paired t-tests to confirm that each subsequent infusion was significant. So each jump, as you can see, is significant. But most importantly here, you can also see that there was no significant difference between the comorbid PTSD group in dark green and the non-comorbid PTSD group in light blue. So to put these results into perspective, the kids has a meaningful change threshold of 3.5 points of improvement. And you can see here that both of our groups succeeded this improvement, demonstrating that a clinically meaningful effect was found. So a 4.37 point improvement in the comorbid group and a 4.08 point improvement in the non-comorbid group. So then for the next part of my analysis, I was wondering whether these comorbid PTSD symptoms were affected by the treatment. So I conducted a paired t-test and SPSS to compare the PCL5 scores at baseline and then after the 4 ketamine infusions. And here my analysis revealed that the PCL5 scores declined significantly from this baseline score of 49.77 to after infusion 4, 39.51. And interestingly, at the participant level, 62 people's scores declined and 17 people's scores increased. And for those 17 people, they were actually non-responders on the kids. So this is something that I'm looking into further to see what the difference might be between those participants. Now, based on the minimal important difference threshold of 9 to 12 points on the PCL5, our sample did demonstrate a clinically significant change in response to the ketamine treatment. But it's important to note that a mean score of 39.51 is still well within the criteria for PTSD diagnosis on the PCL5. So that's 31 to 35 points. And at the participant level, 36 participants met criteria for this minimal important difference threshold. I did decide to dive a little bit deeper into the PCL5 to see if a specific symptom domain was affected more than others. But I actually found that there were significant reductions in all of the symptom clusters. So you can see here by these mean differences that all of them were significant based on these p-values. And you can see the Cohen's d effect sizes here ranging from 0.52 to 0.76. So here, again, we're just showing that all the symptom clusters seem to be affected, not one more than the other. Moving on to adverse childhood experiences. So this was a meta-analysis conducted by Nelson et al. In 2017, and it demonstrated that patients with a history of childhood trauma have poor responses to pharmacotherapy as well as psychotherapy. So here the thought process was that maybe it's not the comorbid PTSD that affects antidepressant efficacy of ketamine, but the experience of childhood trauma. So for this analysis, I wanted to determine if adverse childhood experiences affect the antidepressant efficacy of ketamine for treatment-resistant depression. And here I'm hypothesizing that the antidepressant efficacy of ketamine would be reduced in patients with these higher ACE scores. So the patient population for this analysis includes some of the same participants that you've already seen from the previous analysis. So all of the patients who successfully completed 4 infusions at the CRTCE were reached out to see if they were interested in completing a pharmacogenetic add-on study. And so in addition to this pharmacogenetic data, we were also collecting some additional scales, including the childhood trauma questionnaire, and 84 of these participants agreed to enroll in this study. So I've included our group's most recently published article on these pharmacogenetic results. So if you're interested, you can have a look at this study, but I won't be presenting these results today. So for this analysis, as I said, I had 84 patients, 18 to 65 years old, who were experiencing a treatment-resistant major depressive episode. And then I further divided these patients based on their score on the CTQ. So we have this low ACE group here with an N of 47 that scored 0 to 2 on the CTQ. And then we have this high ACE group with an N of 37 that scored 3 to 6 on the CTQ. So we were able to gather some more demographic data with this add-on. So a couple of things to highlight here. There was no difference in baseline depressive or anxiety scores. As you can see down at the bottom, these are relatively similar. We did have a higher proportion of females in our sample, and our sample was also predominantly white, and they did have some degree of college or university level education. Now again, I conducted a repeated measures ANOVA to determine if antidepressant response differed between the participants with low ACE scores versus high ACE scores. And I found once again that the mean KID scores declined significantly over the 4 infusions. So again, the significant decline for each consecutive infusion, but that there was no difference between the 2 groups. So the high group, so the high CTQ group being in pink and the low CTQ group being in light blue. So on to our conclusions here. Based on our analysis, 4 infusions of subanesthetic intravenous ketamine can produce a clinically significant reduction in depressive symptoms, regardless of PTSD comorbidity or childhood trauma. Interestingly, PTSD severity was also reduced with the treatment, so this study provides us with some preliminary evidence from a real-world sample of a possible therapeutic avenue for TRD with comorbid PTSD and childhood trauma. I want to briefly address some limitations and next steps. So as you can tell, this is a self-report as the main measure, and this is going to be more subject to bias, especially because there was no blinding, randomization, or placebo utilized in this study. I've also not conducted a mediational analysis to determine if reductions in depressive symptoms predict reductions in the PTSD symptoms. So it is possible that because of the overlap in the KIDS and the PCL5 and their different symptom domains, that we're picking up a signal on both of them when one of them might be mediating the reductions on the other. So naturally, a next step would be to conduct randomized controlled clinical trials as well as a mediational analysis. And that brings me to the work of my current lab. So we are currently conducting 2 multi-site ketamine trials for bipolar TRD and 1 multi-site psilocybin study looking at unipolar TRD. And these studies are really going to provide us with that prospective data within an RCT framework to assess whether PTSD comorbidity, childhood trauma, and any other psychiatric comorbidity affects the antidepressant efficacy of ketamine for treatment-resistant depression. So hopefully in the next couple of years I will be able to report on these results, and I would like to thank my supervisors, Dr. McIntyre and Dr. Rosenblatt, for their continued support, as well as my colleagues at the MDPU and our amazing clinic staff and patients who make this work possible. Thank you very much. Happy to take any questions.